What if I told you that millions of people went to bed healthy last night and woke up chronically ill without a single thing in their body changing? No new symptom, no blood test that got worse, no lifestyle change, just a signature on a piece of paper in a conference room by a committee you've never heard of. That's not a conspiracy theory. That's documented medical history. And by the end of this video, you'll understand exactly how it happened, why it happened, and more importantly, what you can actually do about the three conditions at the center of it: high blood pressure, high cholesterol, and diabetes. Stick with me because part 2 is where this gets useful. I'm going to walk through what the research actually says you can do about all three starting today. The 2 questions every detective asks. Here's a habit I want you to steal. Anytime you're trying to understand a health problem, yours, a family member's, or a trend affecting millions of people, ask 2 questions. 1, when did this actually start? 2, what happened right before it started? Most people skip this step entirely. They accept a diagnosis, a statistic, or a headline at face value. But if you slow down and actually plot the data over time, patterns emerge that the 6 o'clock news never mentions. So let's do exactly that with 3 conditions: high blood pressure, high cholesterol, and diabetes. These 3 together now affect well over 100 million adults in the United States alone. That's not a small number. That's roughly 1 in 3 people you pass on the street. If you chart the rate of these diagnoses from, say, 1990 to today, you'd expect a smooth, gradual climb. Diets have changed, activity levels have dropped, aging populations mean more chronic disease. All of that is real, and it would explain a slow upward slope. But that's not what the data shows. Instead, you see a slow climb and then a cliff, a near vertical jump concentrated in specific years. Not because millions of bodies suddenly changed overnight, because the definitions changed overnight. Exhibit A, blood pressure. For decades, the standard for normal blood pressure hovered around 140/90. If your numbers were under that, your doctor told you that you were fine. Then, in late 2017, a panel of cardiology organizations revised the guideline. The new threshold for stage 1 hypertension dropped to 130/80. Think about what that actually means. A person with a reading of 132/82, someone who would have been told you're totally normal in 2016, was by 2018 officially a hypertension patient. Same arteries, same heart, same lifestyle, different label. The scale of this reclassification was enormous. Over 30 million additional American adults were newly categorized as hypertensive, essentially overnight, based on the stroke of a pen rather than any change in their actual physiology. Here's the part that should really make you pause. Other developed countries looked at the exact same body of research, the same clinical trials, the same data, and did not adopt the new threshold. Several major health systems outside the US kept their guideline closer to the old 140/90 standard. Same evidence, different conclusion. That alone tells you this wasn't simply the science evolved. It was, at least in part, a judgment call. And judgment calls can be influenced by things other than pure biology. Exhibit B, cholesterol. Cholesterol guidelines followed a similar arc. Go back to the late 1980s, and a normal LDL cholesterol reading sat at a level that today would raise eyebrows in a doctor's office. Over the following 2 decades, that acceptable ceiling was lowered, first in the early 2000s and again in the following decade. Each time the number moved down, the pool of people now classified as high cholesterol expanded. And each time that pool expanded, so did prescriptions for cholesterol-lowering medication. Statin prescriptions didn't just tick upward. In the years following the first major guideline change, they roughly doubled. Today, tens of millions of Americans carry a high cholesterol diagnosis, and a large share of them are on daily medication for it. Medication that, once started, is often taken indefinitely. Exhibit C, diabetes and a brand new disease category. This is the one that should genuinely surprise you, because it's not just a threshold that moved. It's a category that didn't exist before and then suddenly did. Around 2010, health authorities formalized the category of prediabetes, a diagnosis for people whose blood sugar was elevated but not high enough to meet the traditional definition of diabetes. On its face, that sounds reasonable. Catch problems early, intervene sooner. But the practical effect was that tens of millions of people, by some estimates, more than 70 million adults, were suddenly sitting inside a diagnostic category that hadn't existed the year before. Add up hypertension, high cholesterol, and the diabetes/prediabetes bucket, and you get a number north of 115 million adults now living with at least one chronic disease label that, in a meaningful number of cases, exists partly because of where a line was drawn, not because their bodies changed. Who draws the line? This is where it gets uncomfortable. The thresholds for these conditions aren't handed down from some neutral, disinterested body. They're set by expert panels and committees, groups of well-credentialed physicians and researchers who review the evidence and vote on where to draw the line. The problem is that a meaningful portion of the people sitting on these panels have had financial relationships with pharmaceutical companies, consulting fees, research funding, speaking honoraria, companies that manufacture the very medications prescribed once a new, lower threshold takes effect. That doesn't automatically mean every decision was corrupt. Correlation isn't proof of intent, but it is a conflict of interest, and conflicts of interest are exactly the kind of thing that's supposed to be disclosed and scrutinized, especially when the outcome of the vote directly affects a multi-billion-dollar market. This isn't a fringe accusation either. This concern has been raised inside mainstream medicine itself. The British Medical Journal, one of the most respected medical publications in the world, ran a sustained editorial campaign for years specifically about this issue, examining cases where diagnostic categories appear to have expanded faster than the evidence justified. Physician researchers have written entire books cataloging case after case of this pattern across multiple conditions, including bone density thresholds for osteoporosis and even the body mass index categories used to define overweight and obese. Categories that notably don't distinguish between a person carrying excess fat and a heavily muscled athlete. The question that actually matters. Here's the test that should be applied to every one of these threshold changes. And it's a simple one. Did lowering the number actually help people live longer or feel better? Because that's the entire point of a diagnosis. It's not supposed to be a label for its own sake. It's supposed to identify people who will benefit from intervention. If moving the threshold doesn't measurably extend life or meaningfully reduce serious complications, then what you've created isn't better healthcare. You've created more patients. And this is where the picture gets genuinely concerning, because starting a medication is rarely a single, isolated event. It's often the first domino. A new prescription can bring a side effect. That side effect gets treated with a second medication. That medication brings its own side effect. This pattern, sometimes called a prescribing cascade, is a well-recognized phenomenon in medicine, particularly among older adults, where it's not unusual to see someone taking 5, 6, 7 medications, several of which exist only to manage the side effects of the others. None of this is to say blood pressure, cholesterol, and blood sugar don't matter. They absolutely do. And at the extremes, they are genuinely dangerous. The point is narrower and more specific. A significant portion of the growth in these diagnoses over the last 20 years reflects redrawn lines, not a sudden collapse in the nation's health. Why this matters, beyond the numbers, it's worth pausing on why this isn't just a semantic argument. A diagnosis changes how a person sees themselves. Someone who was told yesterday that their numbers were borderline but fine and is told today that they have a chronic disease often experiences a real psychological shift, a sense of their body as fragile or broken or working against them. That shift can affect everything from their exercise habits to their stress levels to how they talk about their own health to their kids. There's also a financial dimension that rarely gets discussed alongside the medical one. A new diagnosis frequently means a new prescription, and a new prescription means a recurring cost. Not just the price of the medication itself, but follow-up appointments, blood work to monitor for side effects, and in some cases, additional medications to manage those side effects. Multiply that by tens of millions of newly diagnosed people, and you're looking at a shift of billions of dollars annually into long-term treatment for conditions that, in a meaningful subset of cases, wouldn't have been classified as disease a generation earlier. None of this proves bad intent on the part of any individual doctor or researcher. Most physicians prescribing these medications are doing exactly what they were trained to do. Following guidelines they were taught to trust. The concern isn't about individual doctors. It's about the structure at the top, where guideline committees, funded and staffed in ways that create obvious conflicts of interest, set the rules that every doctor downstream then follows without necessarily having the time or resources to question them. A pattern that repeats across medicine. Once you notice this pattern in blood pressure, cholesterol, and diabetes, you start noticing it elsewhere too. Bone density thresholds for osteoporosis were set using a reference population of young, healthy women, meaning that as people naturally age and bone density naturally declines, larger and larger portions of the older population automatically fall into diseased categories. Even though some degree of bone density loss with age is a completely normal, expected part of getting older, rather than a pathology in itself. Body mass index is another example. BMI was never designed as a diagnostic tool for an individual person. It was created in the 1800s as a population-level statistical measure, using it to sort individual people into normal, overweight, and obese categories produces obvious absurdities. A bodybuilder with 8% body fat can register as obese on a BMI chart, simply because muscle is denser than fat. Yet BMI thresholds are still used as a gatekeeping criterion for insurance coverage, surgical eligibility, and medication access in many healthcare systems. The common thread across all of these examples isn't that the underlying conditions are fake. Osteoporosis is real. Obesity-related health risk is real. The issue is that the lines drawn to define these categories are decisions made by committees, using judgment calls about acceptable risk and reference populations. And judgment calls, by definition, could have been drawn differently. And once you understand the numbers themselves are a moving target, the next question becomes the only one that actually matters for your own life. If the labels are debatable, what's actually driving the underlying biology? That's where part 2 comes in. The common thread, insulin. If you look at hypertension, high cholesterol, and diabetes side by side, they seem like 3 unrelated problems affecting 3 unrelated systems: the arteries, the liver, and the pancreas. But there's a signal running underneath all 3 of them: chronically elevated insulin. Insulin's job is simple, in theory. It helps shuttle sugar out of your bloodstream and into your cells for energy or storage. The problem starts when insulin is elevated not just after a meal, but almost all the time. Chronically high insulin is associated with stiffer, less flexible arteries, which raises blood pressure. It's associated with disrupted lipid metabolism, which raises LDL cholesterol and lowers protective HDL cholesterol. And over time, cells that are bathed in constant insulin become progressively less responsive to it, a state called insulin resistance, which is the biological mechanism behind both prediabetes and type 2 diabetes. So when you ask what's actually driving all 3 of these conditions at once, the honest answer for a large percentage of cases is the same underlying process. And when you ask what drives chronically elevated insulin in the first place, the evidence points heavily toward diet. Specifically, a pattern of eating that's heavy in refined carbohydrates and added sugar, consumed frequently enough that insulin rarely gets a chance to come back down to baseline. That's genuinely useful information because it means these 3 separate diagnoses may share a single addressable root cause, rather than requiring 3 separate medications aimed at 3 separate symptoms. What the research actually shows. This next part matters because I'm not asking you to take this on faith. There's real clinical research behind each of these. On diabetes reversal, structured low-carbohydrate and calorie-controlled dietary interventions have been studied in clinical trials for type 2 diabetes, and the results are genuinely striking. In at least one well-known trial, roughly half of participants who followed a structured low-carb program achieved diabetes remission within a year, meaning their blood sugar returned to a non-diabetic range without medication. That's not a fringe result. It's been published in respected medical journals. And it's exactly the kind of information that's supposed to be part of informed consent before someone is started on lifelong medication. On cholesterol. Several non-drug interventions have shown measurable effects on LDL cholesterol in controlled studies. Red yeast rice, a fermented rice product that naturally contains a statin-like compound, has been shown to lower LDL in multiple trials. Niacin, in studied doses, can lower LDL and raise protective HDL. Plant sterols and stanols, found in certain fortified foods, interfere with cholesterol absorption in the gut and can meaningfully reduce LDL. Regular aerobic exercise improves the overall lipid profile, and reducing refined carbohydrate intake has, in a number of studies, improved both LDL and triglyceride numbers. On blood pressure. The evidence here is arguably the strongest of the three. The DASH diet, Dietary Approaches to Stop Hypertension, has been validated in large clinical trials and remains one of the most well-supported dietary interventions in all of medicine. Reducing sodium intake lowers blood pressure in the majority of people, particularly those who are salt sensitive. Increasing potassium intake, found in vegetables, fruits, and legumes, helps counterbalance sodium's effect. Magnesium supplementation has shown modest but real reductions in blood pressure across multiple studies. Regular exercise lowers resting blood pressure over time. And even specific foods like garlic and hibiscus tea have shown measurable, reproducible blood pressure lowering effects in controlled trials. Why common sense combinations are hard to prove. Here's an honest limitation worth naming because I don't want to oversell this. The gold standard in medical research is the randomized controlled trial. You take one variable, isolate it, compare it against a placebo, and measure the difference. That method is excellent for testing a single drug or a single supplement. It's much worse at testing combinations of lifestyle changes. If you improve your diet, start exercising, fix your sleep, and lower your stress all at the same time, a researcher has a genuinely hard time isolating which change produced which result. And running a trial that controls for all four variables at once across a large enough population for long enough to see meaningful outcomes is expensive, slow, and logistically difficult. That's a real limitation of how medical research is funded and structured. It's simply easier and more profitable to test one pill against one placebo than it is to test a bundle of habits against another bundle of habits. But here's the thing. The absence of a perfectly controlled trial testing diet plus exercise plus sleep plus stress reduction combined doesn't mean each individual piece isn't well supported on its own. It just means the combination hasn't been formally studied together as a single package, even though basic physiological logic suggests that stacking several proven interventions should, at minimum, not cancel each other out, and quite plausibly compounds the benefit. What insulin resistance actually feels like. Part of why insulin resistance flies under the radar for so long is that it doesn't announce itself the way an infection or an injury does. There's no single dramatic symptom. Instead, there's a slow accumulation of things that get written off as normal aging or just having an off week. Energy crashes a couple hours after a carb-heavy meal. Difficulty losing weight around the midsection, no matter how little you seem to eat. Sugar or carb cravings that hit hardest in the afternoon. And a general sense of low energy that coffee only partially fixes. By the time fasting blood sugar or an A1C test actually crosses into the quote-unquote pre-diabetic range, insulin resistance has often been building quietly for years, sometimes over a decade. This is actually one of the stronger arguments for catching it early, the pre-diabetes category. Even with all the concerns raised earlier about overdiagnosis, does at least put a name on a process that was previously invisible to most people until it became full-blown diabetes. The problem isn't that early detection is bad. The problem is what happens next. Whether the response is, here's a prescription, or here's a prescription, and here's the full menu of lifestyle options that have real evidence behind them. Building a practical starting point. If you're looking at this and wondering where to actually start, it helps to think in terms of a small number of high-leverage changes rather than trying to overhaul everything at once. On the food side, the single change with the most consistent research support is reducing the frequency and size of refined carbohydrate and added sugar intake, think white bread, sugary drinks, pastries, and heavily processed snack foods, and replacing some of that intake with protein, fiber, and healthy fats, which blunt the insulin spike that follows a meal. This doesn't necessarily mean a zero-carb or extreme diet. Multiple studies on moderate low-carb approaches show meaningful improvements in insulin sensitivity without requiring an all-or-nothing approach. On the movement side, both resistance training and cardiovascular exercise improve insulin sensitivity, but they do it through slightly different mechanisms. Resistance training builds muscle tissue, and muscle is the single largest reservoir in the body for storing glucose. More muscle mass generally means more capacity to clear sugar from the blood efficiently. Cardiovascular exercise, especially done consistently, improves how efficiently cells respond to insulin signaling. A combination of both tends to outperform either alone in the research. On the sleep side, this one surprises people, but a single night of poor sleep has been shown in controlled studies to measurably reduce insulin sensitivity the following day, sometimes by a significant margin. Chronic sleep restriction compounds this effect over time. If diet and exercise are dialed in, but sleep is consistently poor, that's often the missing piece. On the stress side, chronically elevated cortisol, the body's primary stress hormone, works against insulin in several ways, including promoting the release of stored sugar into the bloodstream and encouraging fat storage, specifically around the abdomen. This is part of why stress management isn't a soft or optional piece of this picture. It's mechanistically connected to the same insulin pathway as diet and exercise. What this isn't. To be clear about what this video is not saying. It's not saying medication is always unnecessary. And it's not saying every doctor who prescribes a statin or a blood pressure medication is acting in bad faith. For people with genuinely severe hypertension, dangerously high LDL, or blood sugar deep into diabetic range, medication can be the difference between a manageable condition and a medical emergency. And lifestyle changes alone are sometimes not enough or not fast enough to prevent serious harm in the meantime. The argument here is specifically about the borderline cases, the tens of millions of people sitting just past a threshold that itself has moved multiple times in the last 20 years, who may never be told that diet, exercise, sleep, and stress reduction are legitimate first-line options with real clinical evidence behind them, not just wellness industry talking points. So where does this leave you? A few honest takeaways. First, some of the explosive growth in these three diagnoses over the last 2 decades is real. Diets have changed, activity has declined, and rates of metabolic disease genuinely have risen. This isn't a claim that chronic disease is fake. Second, a meaningful portion of that growth is not biological, it's definitional. The line for what counts as diseased moved, in some cases repeatedly, and the people making that call were not always free of financial interests in the outcome. Third, regardless of where the line sits, the underlying biology that connects blood pressure, cholesterol, and blood sugar is worth understanding on its own terms, because insulin resistance is a real, measurable, and lived, for many people, modifiable process. It's not something you're simply handed at birth and stuck with forever. If there's one thing worth taking from this, it's that a diagnosis is a starting point for a conversation, not the end of one. Ask what the number actually means. Ask what changed to produce it. And ask what the full range of options looks like. Medication is sometimes genuinely necessary, but it shouldn't be the only option presented to you before you've heard about the rest. Quick honest disclaimer, this video presents one perspective on a genuinely contested topic in medicine. Plenty of clinicians and researchers would push back on parts of this, particularly the claim that guideline changes provided no benefit at all. Diagnostic thresholds are set through a real, if imperfect, evidence review process, and reasonable experts disagree about where the lines should sit. Treat this as a starting point for questions to bring to your own doctor, not as medical advice or a final verdict. And if you're on medication for any of these conditions, don't change anything without talking to the person who prescribed it. A few questions worth asking at your next appointment. If you take one practical thing away from this video, let it be a short list of questions to bring to your next doctor's visit, rather than just a general sense of suspicion. Ask what specific number moved you into your current diagnostic category and when that threshold was last revised. Ask what the evidence shows about outcomes for people in your specific range, not the general population, but people close to where your numbers actually sit. Ask what the full range of first-line options looks like, including dietary and lifestyle interventions, before committing to a long-term prescription. And ask what monitoring would look like if you chose to try a structured lifestyle change first, with medication as a fallback rather than a starting point. None of these questions are confrontational. A good doctor should welcome them because informed consent is supposed to include exactly this kind of conversation, not just, here's your diagnosis, here's your prescription, but a genuine discussion of the evidence, the alternatives, and the trade-offs involved in each path. The goal isn't to walk out of every appointment refusing medication. It's to walk in understanding that a diagnosis is a data point interpreted through a specific threshold, that the threshold itself has a history worth knowing, and that the underlying biology, particularly insulin resistance, is something you have real, evidence-backed tools to influence, regardless of which side of any particular line your numbers happen to fall on.